Good morning, everybody. Welcome to our first Parkinson's educational event for 2022. This is the one that we always do the basics of Parkinson's disease. And we have Jack Shen graciously accepted my invitation to prepare and do this talk today. Jack has been with us for the last almost 8 years. He did his residency in neurology at UC, and now he is finishing up a 2-year fellowship in movement disorders. He's knowledgeable, he's bright, he's sharp, but he's nice, and his patients love him. So he's a great person to do this presentation, and I will turn it over to him. You're on,
Thanks,
Jack.
Maureen, for that wonderful introduction. And good morning, everyone. Thank you so much for the opportunity to speak this Saturday morning. I'm just delighted to join you all virtually for today's session. So I am a fellow in movement disorders. So that means I'm a board certified neurologist with this additional subspecialty training, specifically in Parkinson's disease. And this, together with my personal connection to the disease, I have great interest in this area of neurology. I hope to share some of what I've come to learn about the disease while giving you a framework of how I think about my patients. We'll have some time at the end of my presentation for questions, so if you don't mind holding them until then. So this will be our agenda this morning. So I'll explain a little bit about some of the history behind the disease and how it came to this name, and I'll try and explain what I really mean when I say Parkinson's disease, or PD. We'll talk a little bit about the symptoms, how we make the diagnosis, and some general guidelines about treatment and management of the condition. So I first want to start with some historical trivia and context. Parkinson's disease is named after an English physician, Dr. James Parkinson. He was a surgeon apothecary, kind of the general practitioner of his time, just like his father, in London. That is what now is called the Royal London Hospital. He was a man of many pursuits. He was the founding member of the Geological Society of London. He was later honored for his role in paleontology. He actually has a few fossils named after him. He also had interest in politics. This plaque you see here is displayed at his old home in London. And the funny thing is it's incredibly difficult finding a picture of the gentleman. When you search his name in Google, the 2 most common photos you find are of other gentlemen with the same name, but it's not him. So I don't really know what he looks like, to be honest. More relevant to us, though, over 200 years ago, during the infancy of neurology, he was really the first one to describe a set of 6 patients with a clinical syndrome, meaning a collection of symptoms common among those patients, with what he called shaking palsy, and what is better known today as Parkinson's disease. Here's a short excerpt from that report. He's essentially describing tremor, the posture changes, the walking impairments associated with those patients. And obviously, with the lens of the year 2022, over 200 years later, we appreciate the many limitations of his essay. Neurology was just a budding field. Treatment with Levodopa was still at least 140 years away from this paper. And back then, nobody was thinking about genetics or environmental factors. Despite all that, he still deserves a lot of credit. So what do I mean when I say PD, or Parkinson's disease? Well, first of all, it's a progressive condition, meaning it's one that'll change over time. There's specific features, meaning unique signs and symptoms not seen in other neurologic conditions. And it affects individuals in different ways, meaning there's no universal experience of the disease from person to person. There's an early aspect of Parkinson's that I learned very early on, and it's that no two patients are the same. Some of the symptoms and signs I'll discuss in the coming slides may or may not apply to you or your loved one with Parkinson's. But having said that, I'll attempt to describe what could be considered a garden variety type of Parkinson's disease. Through this, one of the goals is to let patients and caregivers know that despite Parkinson's not being the same for all patients, there is a common thread within Parkinson's out there. So that's to say, if you are dealing with certain aspects of the disease, there is likely someone out there who can sympathize with some of what that is for you. Going a little bit deeper, this diagram distills Parkinson's disease into a very simple model, and one that you would commonly find if you looked up PD in a textbook or on a website. So let me try and explain this diagram for you. The cells in the brain, or neurons, which are these blue structures here, communicate with other brain cells inside the brain using natural chemicals manufactured by the brain itself, called neurotransmitters. The key neurotransmitter in Parkinson's disease is dopamine, which you can see represented by these red spheres. Dopamine is necessary for normal movement, among other things. The simplest way of putting this or explaining this model is that there is low dopamine levels within Parkinson's, causing your symptoms. The exact way this came to be in someone with PD is largely unknown to us, but it's reasonable to say that genetic, biologic, and environmental factors are at play here. Obviously, it's much more complex than that, and we still have a lot to learn about this in our field. So this top portion here, that would be someone without Parkinson's. So you can see a nice level or a number of these red dots, meaning there's a nice environment of dopamine used between the two cells. But someone with a Parkinson disease affected brain or neuron, there's just less of this dopamine. Movement disorder neurologists predict that we'll see more and more of PD over the coming decades. You'll hear numbers like 1% of people over 60 will be diagnosed, or 5% of people over the age of 85 may be diagnosed in the future. But it's not just a disease of the elderly. In fact, about 10 to 20% of those who are diagnosed are under the age of 50. Estimates suggest that Parkinson's disease affects about 1 million people in the US. Around 60,000 Americans are diagnosed with the condition every year. And perhaps more than 10 million people worldwide are living with Parkinson's disease currently. It might even be the fastest growing neurological condition worldwide, thereby surpassing Alzheimer's disease, which is something we might see in the coming years. And there's a few ideas as to why we're seeing kind of this trend of cases. But as I said, there's still a lot to be learned here. So we've started very broadly at this point, and I want to bring you closer to the examination room now. And we'll do that by talking about the characteristics of Parkinson's disease. First off, with these key features. Bradykinesia, which is the term we use when we see slowness of movement with decrement, or gradually smaller and smaller movements. This is always present to some degree with one or both of the following. Rigidity, which is the term we apply when we're passively moving extremities, your arm or your leg, and we feel this resistance throughout the movement. You may have heard your neurologist use the term stiffness and or cogwheeling to also describe this phenomenon. The next key feature which is present about 20% of the time, or sorry, 80% of the time, is tremor at rest. And that's tremor, or this kind of shaking, rhythmic, oscillatory movement of an extremity, a hand, a leg, a foot, that comes on most prominently or most obviously when you're at rest. So total relaxation, like when you're distracted, watching TV, just sitting there reading a book, the tremor might come out. 20% of the time, there is no observable tremor. So this is not always there, in other words. There are other motor features or movement changes with kind of these common phrases that we use in the clinic. Doctors and patients will kind of describe, and this is certainly not an all-inclusive list, but Parkinson's disease, we think, or we see, it usually starts on one side of the body. And through the years of progression, this difference between side to side, right to left or left to right, we see this persistent difference between the sides, even as the disease progresses. Patients will describe kind of a changed posture. They're stooped forward. They have trouble getting themselves upright. It's probably most obvious while a person is walking, during which you'll also see an arm not swinging as much. So when you're walking, especially when you're walking a little bit faster, your arms will swing to maintain your balance. And, it's kind of the normal circuitry your brain has been programmed to do. But what we see in PD is one side, usually the more affected side, will not swing as well as the other. Sometimes this is really subtle, sometimes it's more obvious. I've also seen patients where both arms don't swing as well. What that means, I'm not entirely clear, but it's something we see. While they're walking, you'll see short shuffling steps. So it might take a little bit longer to get out of the chair. And once they're going, the steps are shorter and shorter and shorter. And you'll see more of that stoop posture, and you'll see that reduced arm swing as well. This garden variety type of Parkinson's disease, we expect slow progression of these movement changes with a very long duration of disease, of symptoms. And like I said, this is not an all-inclusive list. Patients have also told me, I'm right-handed. I've got some of these changes on my right side, and when I'm writing especially, this is the first sign. As I write, the font kind of trails off and things are just smaller and smaller, and it's harder for people to read what I'm writing. So those are, that's a nice overview of the movement changes, but we also see non-movement changes, or what we call non-motor features. Sometimes these can occur before the movement changes are noticeable by you or the doctor. There's a sense of decreased smell. So you maybe things don't smell as strongly as they once did, or maybe the taste of foods have changed. A lot of times there's constipation would be a key non-motor feature. It's something we always ask about because it's a quality of life issue, and it's something that we can treat effectively if it comes up. This next one is pretty interesting. It's what we refer to as dream enactment behaviors. So these are movements that occur while someone is fully asleep. And the patient or whoever is doing these behaviors may not know that they're doing it, but sometimes your bed partner will say, yeah, sometimes, whoever it may be, they'll yell out in the middle of their sleep, or they'll flail an arm, flail a leg. Those are movements occurring while the person is dreaming most intensely. What normally happens is your body is paralyzed during those most intense periods of dreaming. But that's not the case in Parkinson's disease. So the person will act out their dreams and you wake them up and they might be able to tell you about what they were dreaming, but they don't know that they were doing these things. This is something else that we can easily treat as well. There's also mood changes associated with Parkinson's disease that might manifest as a little bit of depression, maybe anxiety, change in someone's motivation to do things. Sometimes we'll see a change in their thinking too. Sometimes with the wisdom of hindsight, we can identify some of those non-features or non-movement changes. And we can determine that, these were things that were happening perhaps many years ago. And it's only that we explore the possibility of this diagnosis that we're able to uncover those changes and tie them in to their diagnosis of Parkinson's disease. What I'm also trying to show here is that, we expect a long duration of disease, meaning the person will live a long time with PD. There is progression of the disease with different symptoms that might come out. Again, some of these may or may not apply to you. In the clinic, the reason why we're asking you so many questions is that we're staying really vigilant and proactive in screening for some of these symptoms so we can diminish their effect on you and their potential consequences. By that, we're trying to flatten these curves, if you will. Now, let me bring you inside the exam room now by answering, how do we make the diagnosis? Parkinson's disease is a clinical diagnosis. That means we have a set of criteria that have been scrutinized and researched that apply very specifically and only to Parkinson's disease. And we come to those criteria by really these two steps. Step one is meeting you in the clinic, interviewing you, asking about symptoms, and constructing a timeline of any movement or non-movement symptoms you might have had. We discuss how they've changed over time, how they're affecting you currently, because that helps guide our plan of action moving forward. Next, with step two, we perform a very detailed physical examination where we might ask you to do multiple maneuvers like hand and leg movements. I'm sure a lot of you are familiar with these. We might examine how you walk, have you do some balance tasks. I will tell you a secret by saying that the examination begins as soon as we sit down together in the room. I'm already taking stock of any tremor, abnormal movements I'm seeing, the speed and range at which you move, whether or not you use your hands to talk, or if one of them is not moving as well as the other, the volume of your voice, how frequently you're blinking, how you're adjusting your position in the chair, things like that. That's whether or not you notice we're doing that, we are doing that. Very rarely after these two steps will we order additional tests. If the story fits, if the examination fits, we've met criteria for the diagnosis. But every so often, and over the last 2 years, I can only count maybe on 2 hands the number of times I've ordered this test you might have seen. It's a dopamine transporter scan, or a DAT scan. As I was mentioning, in Parkinson's disease, the dopamine system in the brain is affected. And so with this scan, an unhealthy system shows less color. So if you look at this this left image, that would be someone without Parkinson's disease. But you can see here in this panel, there's just less color. That is one indicator of a reduced dopamine system within the brain. So this test can be abnormal in Parkinson's disease, but also other Parkinson's disease-like conditions. This test alone does not diagnose the condition because of that fact. Again, this test is abnormal in Parkinson's disease and other Parkinson's disease-like conditions. So, the key takeaway here is if the story fits, the exam fits, I don't need this test because I have very high suspicion that we have the correct diagnosis. Very briefly, there are several Parkinson's disease-like conditions, or what we call Parkinsonisms, that not only have different symptoms and features apart from Parkinson's disease, things that we're screening for when we talk to you in the clinic, but those different symptoms will have a different progression or evolution over time. And so we're looking for these features with our interview, with our examination, because they'll alert us to the possibility of these other conditions. And therefore, we would have deviated from the garden variety Parkinson's disease picture. And again, these conditions may also have an abnormal DAT scan or dopamine scan. And that is why the timeline of your symptoms and the examination are so important. The exam the DAT scan cannot tease apart these other conditions from one another. I won't be discussing these conditions beyond that as they're kind of outside the scope of this talk. So I've been hinting at the following points thus far with my presentation. There is no confirmatory test for Parkinson's disease. There's no test like a diabetes blood test or a cholesterol measurement or an enzyme test that we can order that says 100% without a doubt you have Parkinson's disease. If you remember the second slide of the presentation, we discussed how everyone is affected differently by Parkinson's disease. For that reason, a logical conclusion based on what we've observed and learned thus far is that there are most likely various root causes to explain the differences between patients. An unhealthy dopamine system is perhaps the downstream commonality, meaning that's perhaps what is common across all patients with Parkinson's disease. But how that came to be could be different patient to patient. The aspiration and hope of our field is to one day learn what specific biological abnormality applies to you and is what is leading to your Parkinson's disease and low dopamine state. And we subsequently hope that we'll be able to correct whatever biological process that may be. This would be our model of precision medicine in the future, or a targeted cure just for one individual. But we're not there yet. There's a lot of work to be done. Some of that work is being done at UC with Dr. Espay's group, something we're very proud of. So we've met in the office now, we've done your exam, and we've made the diagnosis. Or maybe you're coming back to the clinic for follow-up. Based on the time together in the room, we need to determine our plan of action together. As you know, there is no cure for Parkinson's disease, but we can still do so many things to help your symptoms and improve your quality of life. That is the most rewarding part of what I do. There are some general strategies that I pretty much talk with every patient about, or I'm thinking about as we're going through our visit. The first one would be to obviously take care of your other medical conditions. Remember, with Parkinson's disease, we expect a long disease course. So optimizing your other medical conditions, whether that be heart issues, diabetes, et cetera, we need to make sure those things are taken care of to keep your body and mind fit. Quality sleep is really good for your heart, lungs, brain, as is regular physical activity. And again, these are things, I kind of have a checkbox in my head as we're going through our visit. A few slides here on the importance of exercise. I've listed only some of the several benefits here. Exercise keeps you fit. It'll keep your mobility and balance, and as best as they can. Good regular exercise is good for the mind too. It allows you to sustain good attention, thinking ability, and memory. We think exercise kind of trains the brain and molds some of the different networks and connections in the brain. That's something that will be strengthened over time with regular physical activity. Physical activity also gives you good motor strength, muscle strength, and helps you maintain it. It's also good for your bone health. Exercise promotes the release of the chemicals in the brain, the neurotransmitter we briefly touched on. While there's no cure for Parkinson's disease, the current thinking is that good exercise can slow the progression of the disease and protect some of those neurons or the cells in the brain. And collectively, these things will support an improved quality of life. During the height of the pandemic, it was worrying to hear how many patients took a step back in their ability to exercise because of the lockdowns or just being in isolation. And a lot of patients told me that they took a step back with their symptoms because of that, because they weren't able to exercise as they were able to previously. One of the questions I asked, well, I can just tell you, exercise, but how should you be exercising? There's a lot of different models out there, but in general, I encourage a mix of strength training, cardio aerobics, where you're exercising enough to get a pant going. Stretching is good to maintain flexibility. There's probably obvious things that come to mind in terms of exercises that would kind of fit those aspects, but Tai Chi, dancing, and cycling are other ones patients have told me they've enjoyed. There are ongoing studies to determine what the optimal amount and intensity of physical activity should be for Parkinson's patients, but it'll be difficult to apply that amount to everyone in kind of a one-size-fits-all regimen, if that makes sense. But that's where I like to involve our physical and occupational therapists, because they can meet with you during your first session and kind of come up with an individualized exercise program for you. There's a lot of physical therapists and occupational therapists out there who have a specific experience with Parkinson's disease. So those would be good resources to find. Broadly speaking, a reasonable goal for some patients would be 2.5 hours a week of some physical activity. You can find several exercise programs in the community that are centered around Parkinson's disease patients. You might have heard of some of these. This bottom left one, that's a picture taken from the Rock Steady Boxing website. A lot of patients seem to enjoy that. There's LSVT Big, which trains you on kind of amplifying the range and size of your movements. There's a lot of research backing that type of therapy. It's called LSVT Big, B-I-G again. Here's a picture of some Tai Chi being done. Here's kind of a cross-training group of Parkinson's patients. So I'm just trying to show that there are a lot of different programs out there, and one of these might agree more with you than others. It's also really nice to see the sense of camaraderie within these groups. This is a complicated slide, which you don't really need to study too deeply, but with this slide, I'm just trying to highlight that there are a lot of different medications at our disposal that we can consider using in treating Parkinson's disease and the related symptoms. I won't have time to review all of these options, but Levodopa deserves a lot of attention in particular. Since its introduction, this has still remained one of the best medicines for Parkinson's disease symptoms. So levodopa is a naturally produced compound. It's an amino acid that's naturally produced in plants and animals within the brain. This is a very important compound your brain makes because it's used to make different neurotransmitters or other chemicals in the brain. Relevant to us, that would be dopamine. But it's also used, so sorry about that. It's also used to make epinephrine and norepinephrine, for instance. Levodopa as a medication for Parkinson's disease was first reported to be effective in 1968. However, a lot of those patients had nausea with the medication. That's because the medication is taken by mouth, and the body might get a hold of the medication. By that, I mean the organs from the head below the head might use the compound before it gets to the brain. So that could lead to nausea. But in 1975, the FDA approved a combination medicine with levodopa and carbidopa. So the carbidopa blocks the nausea effect associated with pure levodopa when it's taken by mouth. Carbidopa, when it's taken by itself, has no therapeutic effect. For those who remember Latin, I have more trivia for you. The name Cinemet comes from a combination of Latin words. Cine, which means without, and emit, which means passing through. This effectively, when combined, means without emesis or without vomiting. Levodopa is essentially nowadays not prescribed without carbidopa included in the formulation due to that benefit. Most commonly, the formulation that contains 25 milligrams of carbidopa and 100 milligrams of levodopa is what we'll prescribe. Here, there's a picture. They commonly come as yellow pills, but there are some differences manufacturer to manufacturer. That's something we don't worry about too much, as you know, this is a pretty well-established formulation, and I haven't had patients notice. I can only maybe think of one or two that have said they can tell the difference between manufacturer and manufacturer, but suppose it's plausible, but it's something we don't really think about or worry about in the clinic. So we use the terms Cinemet and carbidopa levodopa interchangeably. Cinemet for me personally is easier to say than carbidopa levodopa. That's a lot of syllables. I want to just share a few tips that have come up during my experience thus far. The first one is that there's no magic formula where I can take your age, your weight, your height, etc., to calculate what is the exact dose that you need. Determining that dose, the most effective dose for you, is based on what you tell me in the clinic by the examination and how you've responded to the medication. So you're a central player in that. You know, it's an open dialogue, and we have to collaborate in determining what that dose might be. This is a medicine that's taken multiple times a day, and that's because it only lasts in your bloodstreams for a short amount of time before your brain absorbs it and uses it to make the compounds from it. And again, that's why it's taken multiple times a day. In other words, the levodopa you take in the morning has been used up by the evening time, by the time that time is, you know, all those hours have passed. Taking the medicine on a regular basis, on a regular schedule, replaces what your body is using throughout the day. The brain likes a steady supply of the medication, of the compound. And again, this is a naturally occurring compound or chemical within the brain. it's common for Parkinson's symptoms to be less controlled when the medicine has exited the system or has been used up, and especially when you've missed doses. I'm sure you've noticed some of that in your own experience. We want you to have the benefit from the medication while you're awake, up and about, so that you can be productive and enjoy life. Therefore, your doses should cover your waking hours, your morning, your afternoon, and evening periods. It seems like the brain and the body needs less dopamine while you're asleep. So the medicine that you're taking as you're climbing into bed is probably providing limited benefits. The caveat is that in some patients, you might need the medicine at bedtime or during the overnight period while you're asleep, especially if you're someone who has Parkinson's symptoms that interfere with your ability to sleep comfortably and through the night. We don't typically start out needing this medicine at bedtime, but it's something that, as part of our interview, we're determining whether or not you will need. You also read on the internet that high protein meals will interact with the absorption of the medicine when you take it by mouth. That is true, but it's something we don't place too much importance on unless you're someone who's very sensitive to that effect. If so, there are strategies we could do, changing the time you take medicines compared to when you eat, or I've also just increased the dose right before your more sensitive periods to kind of counteract that effect. And so when I think about how you're being dosed throughout the day, I almost have an image of kind of a wave graph like this in this bottom figure that would correspond to times when the medicine is at its most effectiveness, at its most effective periods, and also when it might be wearing off, or when you're not being covered through the day, when you might have more symptoms, for instance. So our strategy, again, with levodopa is to replace what your brain would have naturally made and what it needs. Dr. Espay likes to give a couple analogies to help you think about that point. We're not trying to give you as little as you need so that you can get by, but we're trying to give you as much as your body needs. If you think about a patient with low thyroid function, that would be like giving them the right amount of thyroid they need so that they're at a good balance. Similarly, with a patient with diabetes, we give them the right amount of insulin so that their sugars at a good level throughout the day. Does that make, I hope that makes sense. There's a lot of myths out there about levodopa that I've heard from patients and even other doctors. Because levodopa has been around for so long, the field of movement disorders has studied the drug extensively and with a lot of scrutiny. These are three common myths that are untrue and have been debunked at this point. The first one is we should withhold levodopa as long as possible because there might be complications. Once we start levodopa, there's a clock that's ticking that, we've put you at the risk for complications related to the medicine. And that's not true. In rigorous clinical trials, studies have directly compared patients who've started at early levodopa versus those who have started later. And the patients who started the medicine earlier experienced robust benefits sooner and enjoyed those benefits for a cumulatively longer period of time that translates to overall greater quality of life and less disability and aggregation. Compared to those who started levodopa as late as possible, those patients had uncontrolled symptoms for a long period of time, effectively being shortchanged from a possible benefit they could have had. We've also come to find that the factor that correlates most with complications of Parkinson's disease is how long in years the patient has had the disease rather than when they may have started levodopa. Sometimes those will correlate, but it's definitely the time factor with it, living with the disease that puts you kind of on that trajectory. And levodopa is not like a narcotic or opioid or alcohol where your body develops tolerance and might need magnitudes of order more of that substance to have some effect on your body. It is true that your levodopa dose will most likely increase through the years. That's because the dopamine network in your brain reduces over time. That's that progression. And changes in doses that might need to be made are often made in small increments as we talk about your symptoms and try and manage them. This is another busy figure taken from Dr. Espay's publication last year, where just to basically explain, the more teal or blue color that you see, the better the symptom control. And each of these bars represents different groups of patients and when they might have started levodopa. This top row has the less overall disability during the time period, and that's because they've had better symptom control earlier on and more robustly compared to those who had delayed start or were withheld from the medicine as long as possible. So this might help if you're a visual person like me. Just a quick note about an advanced therapy available to those with Parkinson's disease, and that's deep brain stimulation, or DBS. This has been around in some form since 1997 for the use in Parkinson's disease. And it's not something that we will willy-nilly just send you to the operating room for. There's a very extensive process where you meet a neurologist, a neurosurgeon, a neuropsychologist, and where there's a conference talking about your case and whether or not this is a good option for you. March 19th, Dr. Manderber will be talking at PD EDU about different DBS systems. So I would encourage you to attend that talk. He has a lot of experience in this field. And with progression of the disease, there's different symptoms that'll come up. There's a multitude of symptoms that could be related. Your movement disorders neurologist will remain vigilant and proactive in helping you diminish these symptoms and potential consequences. And I want to recognize the care partners in the audience and all those out there for your steadfastness and your resilience as well. I'm sure there's quite a few of you in the audience today, family members, care partners, caregivers, etc. For you, it's important to make sure you also have a support system, that you take time for yourself, and also your experience is unique too. That's something we don't forget. It's good to identify stress factors for yourself and others, and take care of yourself, forgive yourself and others, and we can have still a lot of quality of life with this condition. So it's also good to reflect on the positive as well. With my last few slides, I want to just address a few frequently asked questions that have come up in my experience by families and patients and their families. The first one is, what stage am I in, and how does that compare to last time, and what stage is coming? Again, the disease is different for every patient. We don't have stages, or we don't think that way clinically. It's not like cancer, for instance, where the stages are very, very important and define kind of how you're treated and such. The stages you see that are used to describe PD, they're more for research purposes, and they're more, I think of as descriptive terms. Being at one stage doesn't put you on a well-defined trajectory in terms of how you'll progress, because again, it's different patient to patient. Your progression and resilience are unique to you, in other words. So I honestly don't think about these stages when I'm classifying my patients. I focus more on what's important to you at the visit and what's bothering you at that moment and what we can do about it. Another question is, my Parkinson's symptoms, they're suddenly worse. My tremor is a lot worse overnight. My other symptoms are just all of a sudden uncontrolled, and I'm a totally different person. There might be a few reasons for that. Stressors, whether they're the good or bad kinds, if you're really excited, if you're happy, or if you're stressed or you're anxious, that, for instance, can momentarily worsen your tremor. If your Parkinson's symptoms are suddenly worse, I also think about if there's an underlying infection or metabolic issue, whether or not you're sick, you have a urinary tract infection, or some other markers of a metabolic issue that's underlying, and those would need to be ruled out. And then I also ask or consider whether or not there's been a dramatic medication change. If you've missed your medication, or there's another medication that was recently added that have had side effects and therefore magnifying your Parkinson's symptoms. So we expect slow, somewhat predictable progression with your disease. This slide is pretty important, and I'm often asked, what medication should I avoid? And there's probably two main groups. This is not an exhaustive list, but the first main group that should be avoided are medicines that block dopamine in the brain, or what we call neuroleptics in medicine. I've listed a few of those examples there. Another group of medications to avoid would be really strong anti-nausea or vomiting medications. These also have an effect on dopamine. And as always, if there's any concern about a medication you're considering starting, feel free to reach out to your doctor so we can clarify that for you. I see some people taking notes. We'll leave this on the slide for a few more seconds. But the main two groups are dopamine blockers and really strong nausea medications. Okay, another question is, well, you've just diagnosed me with Parkinson's. Will I pass it on to my children? And what's the risk for my children? About 90% of people, that's a big majority, have no known genetic risk. And it's very likely that their children or family members will never develop Parkinson's disease. Having said that, there is a known genetic risk or variation that accounts for maybe 10 to 15% of Parkinson's disease. So, this genetic risk is probably giving a different biology causing their Parkinson's disease. And a good rule of thumb is that the younger the disease begins for that patient, the more likely there is an underlying genetic cause. So, these are patients who are in their 30s, and their 40s, potentially, though that's not always the case. Take that with a grain of salt, please. And even for those who have maybe a genetic mutation, the likelihood of them developing Parkinson's is still low. Obviously, there's a lot more to learn within this realm. And with that, I want to thank you for your attention this morning. And again, it's been such an honor to speak in front of the group today. If there are questions, I think we have a few minutes to go over them.
Thank you, Jack. That was really helpful. I especially like the part about when a person first comes in the office, we're already eyeballing them. And that's true. When I see a patient, a person I haven't seen before, that's just it. You take an overall assessment as soon as you walk in the room.
Right, and actually it's when the medical assistant is bringing you back to
Yeah,
the corner of
Mhm.
my eye, I can see you being weighed, getting your vitals taken, and that's part of the exam too.
Right.
If anyone has a question, please feel free to unmute themselves at this time. I did press the button asking everyone to unmute, so there should be a little pop-up on your screen.
I have a question.
Yeah,
I was reading this book called The New Parkinson's Disease Treatment Book by Dr. Eric Azagog. He's at Mayo Clinic. And he was talking about homocysteines and how he thinks people that are on carbidopa, levodopa, he thinks they would benefit from taking prescription level vitamin supplement that has folic acid, vitamin B12 and B6. And it takes care of the homocysteine problem.
Yes, that's a very astute question you ask. What's being referred to here is the homocysteine level, which is it's a particular metabolic compound we can measure in the blood that might be indicative of certain vitamin deficiencies. That could be B12 or B6 or pyridoxine. Very rarely we can see that levodopa as part of that whole metabolic process. It might consume some of those vitamins. And so we supplement vitamins to maybe replace some of what is needed, but also those vitamins can lead to other symptoms like numbness, tingling, fatigue, low energy, things like that. Folic acid, B12, those are generally unharmful, even in excessive quantities. B6 at very extremely high levels can lead to other symptoms. So if I see someone who's been on B6 for a long period of time, I might check their level just to make sure there aren't other B6. But yes, I do have patients on kind of similar supplements.
Thank you.
we have a question in the chat from Lindsay Morris. Are there any studies that support CBD oil having a positive impact on Parkinson's?
That's a good question. There's still a lot to be learned in terms of the effect of CBD on Parkinson's. I'm aware of any recent trials that have come out with very rigorous data. CBD has been studied probably most intensely in the treatment of medication-resistant seizures or epilepsy for a certain group of patients. And that's been effective there. When I'm asked this question, it's hard for me to comment because I can't show you the data for this. Another consideration is where you're getting the CBD oil. So, you might get from a store or some type of facility where maybe the amount of CBD you're getting is unregulated and different compound to compound. And so it's just hard for me to comment on the effect, but I'm not aware of any recent studies that have come out. There's another question in here. How does a brain spec test show dopamine levels? So the test isn't a direct measure of dopamine in the brain. This is perhaps more technical, necessary, but basically you're given a tracer through the blood that is taken up in the brain, and some time will pass where
Carol Simpson.
After which you've received the compound, they'll scan your brain. And what we're looking for is the integrity of the dopamine transporter between neurons. So a patient with an unhealthy dopamine system, there will be less indication of that transporter inside the brain with that test. So it's not a direct measure of dopamine levels in the brain per se, but it's a kind of a secondary measure of the effect of dopamine levels in the brain. Hopefully that makes sense.
Thank you.
Just a quick addition back to the CBD oil question.
Please.
Dr. Jacob did a presentation a couple years ago at the Sunflower. And the studies that she cited at the time, first of all, the numbers were very small, like 6 or 8 people. And then, so numbers make a difference, right, in the outcome. And the outcomes were equal. So it didn't really show any benefit.
Thank you.
We spent $400 on CBD oil. You remember?
Do we have any other
Okay.
questions?
I have a question, yes.
Yes, go ahead.
Dr. Shen, your CV mentioned Botox, your experience with Botox, and wondering where it fits with the, motion disorder like Parkinson's. If you've had any experience with it within specialties like urology.
Yes, thank you for the question. So botulinum toxin, or what's more commonly referred to as Botox, is one of the advanced therapies a movement disorder specialist might use for the conditions we see. In Parkinson's, some patients might need it for a few symptoms. One of them is what we refer to as blepharospasm, or excessive blinking of the eyes with even forced eye closure. We don't fully understand it, but the thinking is that the network within the brain has led to this excessive contraction of the eyes. And we can apply some Botox injections or botulinum toxin injections to the eyes to help them control those muscles better. That's one application. Another one is excessive drooling. We will apply a little bit to the salivary glands to stop some of the production or reduce the expression of the saliva if it's really bothersome. And then there's other patients who might have abnormal posturing of maybe their head or an extremity, where a little bit of that injection can relieve some of that discomfort. But we like to do management with medications first, because a lot of times what we see is that a suboptimal dose or less or not enough medication is leading to some of those symptoms. And there's other fields of medicine that will use botulinum toxin too. There's a variety of applications outside of my expertise.
Very good. Thank you, sir.
We have-
Oh,
Hello, Ray. Yeah, go ahead, ask your question. Then we have
Okay.
one in the chat.
all right. Is there a certain age that you can go through this that procedure that you use for the brain? I'm 81 years old, and I just wonder if it's anything dangerous or something to have an operation for that. The other thing is that I have a lot of allergies. Would that have an effect on it, or would that, increase the risk of it? I've been taking Levodopa for about 6 years, 5-6 years, and this year, it is starting to. I could feel that I could probably use an increase in the dosage. I've been very, very nervous for I'm a little lost with that, but I noticed that it's been very shaky, and especially the hands. And I noticed that it's on the right side, then all of a sudden it could be on the left side. And these are all the questions that I don't know if it's right or not. And I've been just having doctors look at me and then look at the shaking of it, and oh yeah, you got Parkinson's. And uh, I would like to know if there's a clinical way of finding out, something where I could take tests or something that you could give to find out.
Sure, sure. S- Okay. So, question, what determines whether or not you're a good candidate for deep brain stimulation? There's a lot of factors that we'll have to look at
Okay.
based on your history, your response to the medication, maybe why medication increases wouldn't be tolerated by you. We also look at your other medical conditions and, your chronologic age, you being 81, isn't exactly saying how old you are biologically, if that makes sense. So some of us will age more gracefully than others. So that's why we have a very comprehensive evaluation process. In terms of the progression that you're commenting on, as I said, over years, we might have to adjust the dose. And I'm wondering, I'm asking that question for a lot of my patients when I see them. So, your question highlights asymmetry, the difference between the side. It highlights the progression. There is no test to determine what is the dose you need. What's also important, though, in that is that what is the response to medication been for you, or why have we not been able to go higher, if that applies to you? So I would speak to your doctor and kind of ask that question. Do you think a higher dose would be warranted here? It could be a higher dose or another dose to cover those hours of the day where you might have symptoms.
Well, I'm at Bailey right now, and that's a place where they have the elderly and that. And they're watching me, but I asked them when I get real shaky and that with the tremors that, can this be lessened? The shaking and that. And they said that they would have to call the doctor and find out if there's if they could increase that dosage of carbo.
So Ray, do you have a movement disorder specialist?
Well, I did go to a neurologist, and he was very hard to understand, and I won't go back to him. That's the reason I'm calling with the UC Health. I'm trying to get in up there so that with some kind of a appointment and talk to you that way, and it's just it's a big question.
Okay, so Ray, why don't you give me your last name and phone number, and then
Okay.
we can take this offline. I can call you next week and see what we can do.
All right, it's Raymond,
Mm-hmm.
and it's SUNDERHAUS, Sunderhouse.
Oh, okay.
And my phone number is 513-604-7107.
Okay. I'll call
Is
you
there-
and see what I can do to help. Okay?
Is there a way that it will be identified on the phone that it's coming from you or UC or something? There's so much scam going on now that's unreal.
If I call, I will call from my personal cell phone.
Okay,
And so my name might show up. It depends on your phone. Okay? But
Yeah.
I can leave a message and you can call me back.
okay, that sounds good. Yeah,
Okay. We
Yeah.
have one more question in the pool, I believe.
thank you, doctor.
Thank you, Ray. Thanks, Maureen.
Mhm.
Can you touch on Lewy body dementia? So this is another Parkinson's-like condition where we will see some of these motor problems, these movement problems. We might see some of those non-motor problems as well. But these are patients who might have their thinking ability or cognition affected a lot earlier in the disease course. And that's just one of the things we might come to find during our visit. The treatment and management of Lewy body dementia is not too different than what we would do for kind of a garden variety type of Parkinson's disease, but there are other things that might come up. And so if you think back to that bar graph of progression, maybe some of those symptoms might come on earlier than others. And again, it's different for every patient.
How close are they getting to a cure?
You go, Jack.
Not soon enough.
You all are laughing, but they put an awful lot into cancer. And this isn't any different to me.
Right. No. I wish we were sooner. And it's not because there's been a lack of effort in determining whether there's a cure or not. But I think part of the issue, and what makes sense to me, is that because patients with Parkinson's are different, their biology is probably different. So if you cast a wide net and apply one treatment, it probably won't be effective for the collective group. Perhaps there are individuals we can identify with the specific biology for which that therapy would work. And so this is part of the basis for some of the research we're doing at UC, where we might be able to identify patients who have a certain biology between them, even if their Parkinson's looks different. And there might be a therapeutic in the future that we could apply for those specific biological patterns. That's the hope, at least.
Okay.
Thank you, doctor. Not to trying to wrap this up, because we do have a panel portion, but we could probably take one or two more questions and then we'll have to move on to the panel. Is that okay, Maureen and doctor? Are we okay with
Yeah,
that?
that's fine.
Absolutely.
I think that's good. Mhm.
Great. So we have one question in the chat. What about alcohol?
You go, Jack.
Alcohol. Well, I think, yeah, this is a good question. There's a lot of research out there where you'll hear kind of supporting, not supporting regular alcohol use. This one's hard to answer. I don't think there's any protective or clear, robust protective effect from alcohol against Parkinson's disease. What would be reasonable to say would be moderation, and maybe a drink here or there might be okay, but obviously everyone's different. You should talk to your doctor about your medical comorbidities and what they think, since they'll know your medical history better. But this is not something I would routinely recommend.
Yeah.
Right. But I tell people in a celebration or, something unusual, of course, have a glass of wine or a
Yes.
beer or whatever it is that you like, but everything in moderation. Not a bottle of wine a night, be a little bit much, but you have to enjoy life in part of managing a long-term disease.
Absolutely agree.
I'm glad, Jack. Otherwise, I might get fired tomorrow. Okay, I think we can wrap this up now. Julia?
Yes, we can. So thank you, doctor, so much for this wonderful presentation and taking the time to answer everyone's questions. So at this time, we are going to switch to our panel portion of the program. Cheryl has put together a panel for us so we can get some questions from people who live with Parkinson's and some of their care partners today.
I have put together a panel of 6 people who are husband and wife, and they are each going to explain and discuss their experiences with Parkinson's. We have somebody who's been diagnosed as little as 2 years ago and up to over 20 years. So we have a lot of experience on the panel. We have a set of agreed questions, like reactions to the diagnosis and what steps they take to manage their Parkinson's.
Okay. I'm Sarah. I am married to Alan, who's somewhere in here. You'll see him closer later. I am a retired librarian. I worked at Earlham College, And I liked being a librarian because it allows you to learn a lot of new things and help people. Another part of my job that was very important was taking students to Tanzania on study abroad programs. Now I enjoy being with my family, cooking, crafts, and travel. I was diagnosed with Parkinson's in 2006, and it was a very traumatic initiation into the disease. I ended up going to a neurologist over something that I thought was very simple. My arm didn't swing when I walked. I thought it was odd, but I didn't think it was much of anything. I thought maybe it had something to do with my having dislocated that shoulder. But my handwriting began to deteriorate, and I thought that was very odd. So I made an appointment with the neurologist, and off I went for the office visit. Well, the doctor was very late. I had to wait and wait and wait. Finally, they sent an assistant in who did this sort of run-through testing. Then I waited some more, and finally the doctor came in. She was very cold and very haughty. And she said to me, "Well, do you know what you have?" And I said, "Well, no, that's why I'm here." She said, "Well, I have some good news and I have some bad news. The bad news is that you have Parkinson's disease. The good news is that you won't die of it. The Pope didn't die of Parkinson's." Well, at that point, I just went into shock. What are we talking about? And I just wailed, "I don't even know what Parkinson's is." And she said, "Well, I can't tell you. Everybody's different." And at that point, she got called out of the office, and there I was sitting with the assistant, and the assistant said, "Well, this is what Parkinson's is." And he stood up and he shuffled around the office, hunched himself over, looked like that classic image. And I just was horrified. I said, "This is how I'm going to look." And I ran out of that office, ran back to work, ran around finding all my friends saying, "I have Parkinson's, I have Parkinson's." So at least that took care of one of the initial dilemmas. That is, how should you let people know you have it? Well, everybody pretty quickly. So I wasn't done with the doctor yet, though. I had to get my files and notes on me transferred to my new physician, Dr. Espay. And she just didn't do it and didn't do it. And I kept fussing and trying to get her to send the things off. And finally, she said to me one time, "I don't want to see you anymore. You're being too much of a nuisance. You're not welcome in this office ever again." So that was the end of her. And I was very happy to start with another physician. Well, nothing much happened for the first couple of years, and that was good. I was surprised. I thought things were going to go downhill right away. I was afraid of what my symptoms were going to be. I was worried about cognitive decline. I didn't want to appear damaged to other people. I didn't want to be, instead of just Sarah, I didn't want to be Sarah who has Parkinson's disease. And for a couple of years, nothing much happened. And I kept up with all my activities, including taking students to Tanzania for 6 months. So when I got back, symptoms got a little bit worse. And so I started on carbidopa, levodopa, and that was going well. I made plans to go to Tanzania with students again, but this time it didn't work out. I started having strange symptoms. I felt loopy, I felt wiggly. I got in touch with Dr. Espay. He ordered new drugs for me, had them mailed over to Tanzania. I took them, but it didn't help. I was just not in a good shape at all. And I had to leaving Alan in Kenya, in Tanzania. And I came back and had to embark on a full recovery effort. In this new effort, I went through some medication changes with Dr. Espay. He referred me to a psychiatrist to help address my anxiety and depression. I started an exercise program with a personal trainer. I started taking Dancing with Parkinson's class. I joined a support group. I got involved with the Parkinson's Support and Wellness, the organization that's sponsoring this talk, became a board member and a committee member. And after a few years, I got everything back in order, and my symptoms improved, my overall health improved, my outlook on life improved. And I realized that becoming active in the organization was like being a librarian again. It was an opportunity to do more learning and also help people. So I realized I was doing more of my career work in a new setting. And that made me feel good. That made me realize I still was Sarah. But I also realized that I am Sarah with Parkinson's, which was what I was so afraid of. But now I'm not. I can be myself and have Parkinson's disease. So I am Sarah with Parkinson's after all. Now, I would encourage those of you who are new to this, do as much learning as possible. It helps take the fear away. And I would encourage everyone to be involved with a support group. I have learned so much from my peers, and I've been able to help them too. And it just makes the journey much less lonely. So that's my story. I think I'll turn it over to Alan to have him tell you his perspective on things.
Hi, I'm Alan Winkler. As Sarah said, I'm her husband. When she was diagnosed, I was in Columbus at a meeting driving home, and she telephoned me to blurt out that she had Parkinson's. And I immediately changed where I was heading, went to Richmond, where she was located at the time in Indiana, and went with her as she blurted out that she had Parkinson's to everybody she could see on campus. It was a surprise. For me, I didn't have a clue what Parkinson's was. I knew it was a neurological illness, disease. I didn't know anything more about it. And over the last 15 years, I've learned a great deal. I was still working, so Sarah went to things like a dancing class, a variety of things. She began going to a support group without me initially. Early on, that was the one thing that I was able to do, and began to go to our support group at Evergreen once a month with her. A couple of years later, I did retire, and at that time, I began doing many more of the things with her. It included going to the dance class that we participate in Wyoming, and a range of other things. I found myself doing more and more at home. It seemed to me that my job was to make it as easy as possible for Sarah to live as full a life as she could. And that has been the case. But it hasn't been without its challenges. Sarah talked about difficulties occasionally with medication. At one point, when she had come back from Tanzania that first time, and they took her off of the drug she was taking, they did so too quickly, and she had a really bad reaction one weekend before they started the carbidopa levodopa. We got through that, but it was simply an indication that the medications needed to be handled carefully, and it was a lesson that we learned from that time on. When we were in Kenya and Tanzania together in 2010, and she really began to spiral downhill, and even the drugs that Dr. Espe sent over didn't make enough of a difference. She had to come home, and that was difficult because she was not in good shape and had to dedicate herself to getting better, which she did, living with friends. Our house had been rented out. I was left for 3 months with 21 students in East Africa, having planned to do this jointly, and all of a sudden had to do it myself. And not only was it phenomenally lonely, but it was a huge, huge effort. We got through that, and the blessing was that when I was back home and she began to put the pieces together, it made it a whole lot easier. And indeed, she did recover. and has been on a kind of upward trajectory ever since. One of the things that we as a couple have enjoyed doing over the years has been to travel. Both of us were able to travel, and we did so together through our jobs and then on our own. And we went to a whole lot of different places, and it was really a delight. COVID obviously has disrupted that. We didn't see our 2 grandchildren for a year and a half when COVID hit. All of that has been difficult for us and problematic. And like everybody else, we're trying to deal with that as best we can. We have gone to a good number of Parkinson's functions. Sarah has been really active in the Parkinson's community, on the board in Cincinnati, started a support group in Oxford, has been going to a boxing program in Richmond, Indiana, and started a kind of subsidiary of that in our hometown of Oxford, all of which is terrific. It seems as if our lives are revolving around dealing with Parkinson's in many ways, and that's been a good thing. Sarah talked about meeting some wonderful people in the course of this journey, and some of our closest friends are now people from that Parkinson's community, and we value those relationships and associations very, very much. Sarah does not have many motor symptoms, and that's a blessing. There are all kinds of other complications from Parkinson's that we're aware of. We learn more every day about this illness and what it entails. And yet, I'd say fundamentally, we're optimistic. We're doing as much as we can to manage this as carefully as we can. And fundamentally, it's okay. And for us, that's a really, really good thing. Let me stop there. Thank you.
Thank you, Alan. Thank you, Sarah. That was very moving. I really enjoyed listening to you.
Hi, my name is Carlene. This is my husband, Jim. I was diagnosed 2 years ago in 2020 in July by my family doctor. And it was a big month for me. I was retiring as a nurse. I had been diagnosed with sleep apnea, so I had gotten a new CPAP machine and was trying to learn how to use that. And I went to my family doctor for just a routine checkup. And I just casually mentioned to him that I was having trouble with my handwriting. It was getting smaller and smaller, and my hand was cramping. And I've been doing a lot of writing with a program I was working on. And did he think it was carpal tunnel or something like that? And he jumped out of his seat, ran over and started flicking my fingers and checking my arm movement and stuff like that. And he said, "You have Parkinson's." I'm going, oh, Parkinson's? That's impossible. I immediately think of Michael J. Fox. I'm like going, I'm not Michael J. Fox. I can't possibly have Parkinson's. He says, "You have Parkinson's." He says, "I'm going to put you on this medication. And if your symptoms improve, then you'll know that that diagnosis was correct and stuff." So anyway, so that was the situation. Up until then, a full year before this appointment, I had been complaining to my rheumatologist that treats me for osteoporosis, my family doctor, my OBGYN, everything about my toes were curling on my right foot when I would go for a 1.5 mile walk. About 10 minutes into the walk, my toes would cramp up and curl under. I'm telling you, you can't walk. And so then I would mentally try to stop, make my toes flatten out, and then I'd walk tippy toe for about 100 feet or so and get the cramp stopped, and then I could finish my walk. And so I mentioned it, oh, they think it's not enough magnesium, too much magnesium, too little potassium, too much, to this, it was all that kind of stuff. But no one knew what was going on. So anyway, once he says this, I immediately looked online and saw the Parkinson Foundation and read up that they really recommended that you go to a movement disorder specialist. And so they listed the areas, like there's some in Cleveland Clinic, and then there's the UC campus. So of course I live in Dayton, and so it was closer to go to UC. So I called up there and said, oh, my family doctors just diagnosed me with Parkinson, and I'm reading that I need to go to a movement disorder specialist. Well, she said, there's a doctor that's up in Dayton that you can go to. And so I made an appointment and got in with him the following week. And he confirmed the diagnosis. And I said, doctor, when I walk, my toes curl under after about 10 minutes into the walk, and it cramps and I can't walk. And I have to break the spasm in order to finish my walk and get back home. And I says, do you think that has anything to do with the Parkinson's? And he says, no, I don't think it does. And then I asked him some other questions. I says, well, you are a movement disorder specialist, right? And he says, oh no, my specialty is migraines. So I said, well, I thought I was getting an appointment with a movement disorder specialist. And I said, your feelings, I hope, aren't hurt, but I'm going to see someone else. And he says, no problem. So anyway, it took another 5 months before I could get in to see Dr. Coleman at UC. And so he's wonderful. And I so appreciate what his advice has been. I did try the medicine for 1 week. And for me, I'm just not used to taking medicine. I was so dizzy and lightheaded and nauseated, I could hardly get out of bed. And I was just miserable for that whole week. It was like the worst case of flu. And so I thought, I'm not taking this medicine. My little tremor or my little problem with handwriting, who cares? Compared to feeling like you had the worst case of flu, it was a piece of cake. So anyway, so I went to see Dr. Coleman, and I explained to him, I said, I'm worried about the medication. I didn't tolerate it well. And so can I just not be on it? I says, it doesn't cure it. So what's the diff? And he says, but it's the quality of life. He says, if you don't want to take it, that's fine. He says, I think it'll improve your quality of life. I'm like going, So I didn't for 6 months. And then finally in March of 2021, I finally said, okay, because he said he would start me off. He says, I would never put you on that high a dose right out of the gate. He says, that's probably why you didn't tolerate it. I would start very slow. So he did. And I'm telling you, my quality of life has improved tremendously since I started the medication. The other things that I didn't realize, I was starting to have difficulty swallowing. Besides my toes curling, and my handwriting was small. And then I was having problems brushing my teeth. I had to use my non-dominant hand to brush my teeth because I couldn't get it to coordinate. So there were a lot of things that were going on with the Parkinson's that I didn't attribute to the Parkinson's. But once I started the medication, I now have normal, beautiful handwriting back to where it was before. My toes don't curl when I go for my walks. I can brush my teeth with my right hand. And so a lot of things have improved. So what were my fears and uncertainties? I was scared to death. I get all the information on the drugs, and I was scared to death that I was going to have dyskinesias, that I wouldn't be able to drive my car, that I would have all these other symptoms like neurosis, hallucinations, delusions. So I should probably never have read up on the drugs, because in reality, it hasn't happened. And instead, I feel like my quality of life has improved so much better. Also, I've gotten involved with physical therapy, occupational therapy, speech therapy, support groups, exercise, dancing with Parkinson's, everything like that have been so marvelous, been so blessed by having all of that. So anyway, what steps do I that I take to manage my Parkinson's? Well, I'm on kind of a rigid schedule with the cinnamon, taking it on a rigid schedule. So I set my cell phone timer to remind me because I get involved in things and I forget. And I take part of them with having Parkinson's is kind of constipation that I never had before. So I take Metamucil twice a day, and that seems to handle that issue. So my CPAP machine seems to be doing well. I sleep well. I sleep usually 7 or 8 hours a night, so I get a good night's sleep. I'm now all about organic foods. I was the what would you call it? The Roundup queen. I was spraying things, fence lines and stuff with Roundup, killing grass and weeds. I was really exposed myself to a lot of toxins. So now I've done the opposite. Now I choose organic foods. We've got a whole house water filtration system. I've gone the opposite. So I'm trying to minimize my exposure to pesticides and herbicides and things like that. So anyway, so my what advice would I give for someone that's been newly diagnosed is really seek out a doctor whose specialty is movement disorders. It is well worth it. Exercise is so important. Aerobic exercise, strength training, balance, things like that. That was the other thing. I was noticing that before my medication, I was losing my balance pretty often. I had to catch myself from falling a couple of times. Never fell, but I came very close to it because I was just a little unsteady on my feet. But since the medication, I haven't noticed that at all. So I'm still able to do my 1.5 walks. I am retired and just enjoying being at home, being with friends now that we can get out a little bit more with the pandemic. It all kind of happened all at the same time. So it was kind of a little stressful going through the pandemic and stuff. But anyway, do you have anything to say, Jim?
Well, you've said what you said so eloquently. I'm not sure that I can add anything to the part that I thought I was going to say something about, and that is, what advice would you give someone who just found out they had Parkinson's? I think you covered it extremely well. First of all, for sure, find a movement disorder specialist, or you never know what advice they're going to give you or what medications they're going to try to have you take. So you got to get to the right kind of doctor in the first place. And I think your support group has been a godsend for both of us. And it's just a wonderful support group in the Cincinnati, Dayton area. So that's very important. Your exercise you mentioned, and I think that's been important, and I need the exercise too. And take your prescriptions, and your alarm goes off every couple of hours. And I keep thinking it's the phone ringing and you ought to answer it, but it's just time to take your pills. So, and try not to stress out. So those are the same things you mentioned. I'm just summarizing them. The question that I would like to address now is, what ways do I try to help? I need to deal with when to fix dinner, because there's a timing associated with when she eats and when she takes her meds. So we need to coordinate that with some of the other things that are going on in our life. And that's kind of a daily question, is what time do you want to eat? It's usually the same answer, but you never know. And I've volunteered to help clean the carpets. That's physically a lot of work because of the kind of carpet we have. We have a very heavy sweeper. So that's one thing I'm trying to help out with. And encourage the walking and walk with her. And I try to participate in the support group activities such as this. And as she mentioned, we've improved our home water cleanup system based on a recommendation in a book that she read. And our food choices have changed. And I do the daily cooking in the evening meals, so I need to be involved with what the food choices are. And what do I do for myself? Well, we're both retired, so I've pretty much continued the things that I was doing after I had retired. For example, I'm on a board of a credit union, and I still continue to do that, and I enjoy that involvement. And I was doing taxes part-time, and I still do hours, and I enjoy doing that, and I enjoy keeping track of our longer-term financial planning. I like to watch sports. I like to watch football. I like to watch University of Dayton basketball. And I have a number of house fix-up projects. Not that I'm particularly proficient at house fix-up, but it's a lot cheaper if I do it myself. So that's one of my motivations for doing that. And I want to add something to the question. Not only what do I do for my own self-interest, what do we both do together that we enjoy a great deal? And that involves the kids and the grandkids. And we now have a great granddaughter, which is just delightful little girl. And we also are still socializing with a group of Carlene's friends who have been doing things for what, 100 years or so?
About 40 years.
About 40 years. So I've kind of joined that group too. And so we enjoy doing that together. And that's pretty much all I have to say. I appreciate the opportunity to come here and talk about this and listen to other people's experiences.
Yeah, I think the best thing is just to take one day at a time. Don't worry about it and think that you're going to have this or that. Just take what comes and not worry ahead of time, and enjoy what you can do, and be appreciative of what you are able to do, and just be positive, because I think that positive outlook affects your physical and your mental and your psychological well-being. Thank you.
Thank you, Carlene. Thank you, Jim. It was very informative, and I think you got some good advice there, Carlene. Next, we have Elizabeth and her husband, John. And Elizabeth is also going to talk about a program which extends the information from this program. It's a wonderful opportunity for those who are newly diagnosed. She's going to talk about the end of her talk.
First of all, what were my expectations and how did I get when I got diagnosed? First of all, I did not expect to get Parkinson's. I expected to get cancer. There's actually a lot of cancer in my family. My mother and all three of her siblings have had cancer. My mother contracted breast cancer and died when I was 6. Since breast cancer can be strongly genetic, I always expected I would get breast cancer. So when I was diagnosed with Parkinson's in 1998, I said, this is the wrong disease. I'm supposed to get cancer. I wasn't prepared for Parkinson's. Naturally, I was surprised, but not completely shocked, because both of my maternal grandparents had Parkinson's. So my next expectation was that I would be like my grandparents. My grandmother, who lived with PD for more than 15 years, died at the age of 90, was confined to her bed for the last few years of her life. My grandfather spent his last few years refusing to take his PD meds and shuffling around the house with little fascination steps. They were, by the way, divorced, and so never shared their illness or their care. But I thought I knew all about Parkinson's because I knew both of them. But it turns out that as I was diagnosed at age 39, it meant I was young onset, and it's kind of a different progression than the normal. The average age of diagnosis is something like 60 or 65. So young onset is kind of a different kettle of fish. It tends to progress more slowly and sometimes have more or at least different complications down the road. So when I asked the doctor who diagnosed me what the prognosis was, I expected the worst. But he told me that within each individual, PD tends to progress at a consistent rate. So the rate is different when every person with PD. We would not know until I had been observed for a while what that rate would be for me. So I just felt the fear of the unknown. I had no idea what to expect. Another expectation was that I would not be able to be a good mother to my 3 children, who were, at that time were 14, 12, and 9. At that point, I was a single mom and did not know quite how quickly my abilities would decline. But my children were at least initially more of a help than a burden because of their attitude. Their reaction to my diagnosis gave me hope. My 9-year-old assured me that things would be okay. When I said I would miss things like taking my grandchildren to the zoo, she said, "We can push your wheelchair at the zoo, and since you can get a handicap parking permit, we'll even get the best parking place." Now that 9-year-old is 31 and has 2 daughters of her own, and I have indeed been to the zoo with my grandchildren. So then I felt inspired to focus on how I was doing each day and not look too far into the future, because I realized that I might be worrying about things that would never happen or I could deal with when I got there. I heard Carlene say the same thing. You hear lots of echoes from what Sarah and Carlene had said, because there's some pieces of our stories that are sort of resonate. So how has it turned out for me? How was the reality been? The symptoms themselves I have found to be manageable in a way I had not expected. The progression of my Parkinson's has been quite slow, so I've been able to adapt along the way. The symptoms that bother me most are difficulty with walking, posture, and balance. And I also had the toe curling for a while. And I still get that every now and then. And also, I love this phrase, orthostatic hypotension. That means your blood pressure is very low and drops when you stand up, or for me, even go upstairs. But as a lover of words, I get a kick out of just knowing that phrase, orthostatic hypotension. Makes you sound very smart. I've adjusted to increasing severity in each of these symptoms by targeting the symptoms in my exercise and by putting safety rules into place for myself, such as always taking hiking poles when we go hiking. It's not easy to control my tendency to take small steps or my lack of balance, but when I work hard to correct these deficits, I can make a difference. But I must add, it is exhausting. So what steps have I taken to manage my PD? Well, the first and most important is exercise. Again, I echo what the others have said. When I was first diagnosed, I had a friend who set up walking buddies for me, and I tried to exercise 2 or 3 hours a week. Over the years, I have added more and more exercise opportunities. I have done Tai Chi and yoga. I walk or hike most days. I attend Parkinson-specific exercise classes 3 to 4 times a week, work out with 2 different personal trainers who specialize in Parkinson's, and attend PD-specific dance and boxing classes. And in February, I shovel snow. Currently, I exercise at least 12 hours a week and often more. And I truly believe that the reason I can manage my Parkinson's is that I have slowed its progression by exercising a lot. When the rate of decline is slow, I can adapt along the way, and I get used to each new symptom. By taking them on one day at a time, I can deal with it.
12 hours a week.
I've also tried to learn as much as I can about PD, another theme that you heard earlier. I've attended conferences and webinars and meetings. I have read books and articles. I have worked to make information available to others with PD as well. And as I learn more, I've also learned that many families affected by Parkinson's need more information and support than they are getting. This has led me to become involved in the Parkinson's community. My involvement in the local PD community has taken many forms. I have served on the board of Parkinson's Support Wellness for over a dozen years. I served on the program committee for nearly 10 years. I've been instrumental in starting exercise classes, the Dance for PD program, and the Steady Stride Singers. I've started programs for the newly diagnosed folks. This panel discussion was actually my idea several years back. I'm glad that it still works and it is thriving. I won the Sunflower Victory Award in 2018 for my contributions to the Parkinson's community. I find this community involvement very rewarding because it keeps my brain working while at the same time sending me an abundance of gratitude. It also helps me stay connected with others. Keeping that social network active has been especially difficult in COVID times, but it is very important. A recent study actually found that the single best predictor of decline in Parkinson's is a sense of loneliness. I think that's amazing. The single best predictor of decline in Parkinson's is a sense of loneliness. Finally, though it's easier said than done, I think perhaps the most beneficial step I've taken is my intention to keep a good attitude. Attitude makes a huge difference in the amount of stress in my life. Just believing that I'm doing something proactive gives me hope that I can continue to stand up to this disease, and so it won't let it completely control my life. So what advice would I give to those who are newly diagnosed? I would strongly encourage you to start Parkinson-specific exercise program. Find some classes and some activities that you enjoy and stay active. Developing this habit is imperative to keeping your PD manageable. Learn as much as you can about Parkinson's disease. And to this end, I would like to invite you to another program, which, since it follows the basics of Parkinson's, is called Beyond the Basics. This will be a 2-session small group experience just for those newly diagnosed. Well, I'd say within the last 1 or 2 years, but we're not going to make you show your diagnosis card. There's no limit. Beyond the Basics will help you determine what are the next steps you need to take in your PD journey, and what are the resources you need to take those steps. You will hear some of the same advice you're hearing here today. That's because it's so important. We'll tell you again to exercise, but you will also get to meet others with Parkinson's and learn from each other, and you'll learn about the benefits of a support group. This program will be held on Zoom on March 12th and 26th at 11 a.m., just like this one was 11 a.m. So I hope that that would be something that those of you that are newly diagnosed would benefit from, and I hope you'll consider joining us for that. And now, my husband, my care partner, John. You're muted, sweetie.
Can you hear me now?
Yes.
Okay, thank you. Elizabeth and I have been married for nearly 22 years. And if you do the math, given what she said about her onset or her diagnosis, we tied that knot joyfully after her diagnosis for PD, about 3 years. So I've known her very little without PD. We decided early on that our watchword would be, we're in this together. And as she suggested, very subtly, we like to refer to ourselves as care partners, implying a mutual concern with and caring for the needs and happiness of each other. To us, the term caregiver implies attention to the physical and medical dependence of one's partner as a patient. And we both feel a need to support and care for each other. At the risk of embarrassing Elizabeth, I have to say her approach to life makes my role as a care partner relatively effortless. She's upbeat and almost always positive about life, self-reliant, dependable, thoughtful, focused and conscientious, dedicated to exercise and diligent in doing it, and committed to a healthy lifestyle. Also, related to that, an excellent and creative cook. So what can I do to support her? Well, I think one of the most important is to be interested and involved in our joint and her Parkinson's related activities. One of the main ones of those these days is trying to spoil our grandchildren. But examples of other activities that we share are Dance for PD and support groups and going to Parkinson's conventions. It's very much what Carlene and Jim indicated about their own relationship, that they work at this together. Elizabeth and I like to hike together, and to date we've accomplished 856 hikes. We also like to keep track of those. And that's not walking on the city streets, which we also enjoy. Elizabeth has a hobby of identifying and collecting a life list of trees. And that's one thing that we can share. I have grown to be fascinated and affectionate toward trees. She reads to me in order to work on her voice projection. And our joint book list is currently at 203 titles. So we work at this together. Plus any other activity that is together that's fun and that we can share, movies and puzzles and so on. I also try to learn as much as possible about PD with her, noting its characteristics and issues and technical origins and symptoms and medications. We are kind of a study group of two when it comes to PD. And attend her meetings with her movement specialist to provide observations, sometimes opinions, and occasionally memory. I'm sometimes, I should say occasionally, required to remind her of certain things, to take her meds on schedule if she happens to forget, to take life easy and avoid stress. And I also like to help her avoid stress. And perhaps most important, not to be discouraged or disappointed. Troublesome symptoms and discouragement will inevitably enter our lives, but probably won't last through tomorrow. So we work together because we're in it together.
Big thank you to Dr. Shen and to our panel. We really appreciate this is, I believe, one of the most important educational events that we sponsor throughout the year. And I'm always fascinated by what I hear back over the next few weeks from people that participated. It always seems to make a big difference in people's lives, and that's what we're here for. I would remind everybody that we will have a copy, if you will, a recording of today's program available on our website. And this is a practice that we do with all of our educational events, at least since the beginning of the pandemic, and it's a new discipline for us. But you can find previous PD EDUs dating back more than a year now at our website. Again, it's parkinsoncincinnati.org. And we look forward to our next PD EDU in March. And then again, we will have our Spring Forum event in April. So stay tuned, and we'll get all the information for you and the ability to register on our website.